Welcome to Lesson 2 of your antepartum unit. In this lesson, we will cover the concepts associated with pre-existing conditions that result in high-risk pregnancy. The objectives of this unit will include distinguish the types of diabetes mellitus in pregnancy with the corresponding risk factors in pregnancy, associate the insulin requirements during each stage of pregnancy, postpartum period, and with lactation, recognize maternal and fetal risks or complications associated with diabetes in pregnancy, develop a plan of care for the pregnant woman with pregestational or gestational diabetes, identify the risk factors associated with the management of the patient with hyperthyroidism, hypothyroidism, cardiovascular disorders, respiratory disorders, anemia, neurologic disorders, and autoimmune disorders. Discuss the care of pregnant women who use, abuse, or are dependent on alcohol, illicit, or prescription drugs. For most, pregnancy is a normal, happy occurrence, but for some women, pregnancy presents a significant risk to both mother and fetus based on pre-existing conditions. This lesson focuses on the pre-existing conditions that increase risk for both mother and baby. Pre-existing conditions include metabolic disorders, which include diabetes mellitus and thyroid disorders, cardiovascular disorders, respiratory, gastrointestinal, integumentary, and central nervous system disorders, autoimmune disorders, and substance abuse. First, we will discuss diabetes. The perinatal mortality rate for the pregnant woman who has diabetes is about the same as it is for the non-diabetic mother, with one caveat: the diabetes must be well controlled. If the diabetes is not well controlled, the risk increases. Therefore, the goal of managing the care of the pregnant woman who happens to have diabetes is to assist the mother in maintaining strict glucose control. Diabetes is a metabolic disorder in which hyperglycemia is a result of a defect in insulin secretion, insulin action, or both. In the normal person, insulin, which is produced by the pancreas, regulates glucose by assisting glucose to enter the adipose and muscle cells where it is used to produce energy. Insulin is the key for glucose to get into the cell. Without insulin, glucose, no matter how hard it tries, can't get into the cell. Most women return to normal glucose levels after childbirth. However, the recurrence risk for gestational diabetes in the next pregnancy is 35 to 75%. There are other metabolic disorders of pregnancy. Hyperthyroidism in pregnancy is rare. The signs and symptoms of hyperthyroidism are similar to those of pregnancy. In order to differentiate the symptoms of hyperthyroidism, the nurse should look for weight loss, goiter, and a pulse rate greater than 100. Untreated hyperthyroidism in pregnancy can lead to increased risk for miscarriage, preterm birth, giving birth to stillborn infants, or infants with goiter, hyperthyroidism, or hypothyroidism. Hyperthyroidism in pregnancy is treated with propylthiouracil, or PTU, or methimazole, MM. The dose of PTU is 100 to 150 milligrams 3 times a day. Women who breastfeed and continue to take the medication after birth are advised that the medication does not seem to adversely affect the neonate's thyroid function. Hypothyroidism occurs in 2 to 3 out of 1,000 pregnancies. It is associated with increased risk of miscarriage. If left untreated, there is an increased risk of miscarriage, preeclampsia, gestational hypertension, placental abruption, preterm birth, and stillbirth. Medications are given.
Now let's discuss the cardiovascular disorders that affect pregnancy. Normally, the maternal cardiovascular system goes through major changes as a result of pregnancy. There is an increase in intravascular volume. All you have to do is check out the veins of a pregnant woman and you can see this. The pregnant woman also has a decreased systemic vascular resistance, changes in cardiac output during labor and birth, and intravascular volume changes immediately after birth. We'll also discuss the cardiovascular disease classification system. The Class 1, Class 2, Class 3, and Class 4, determined at 3 months and again at 7 or 8 months of gestation as progression may occur. We'll discuss the antepartum assessment of the cardiovascular patient and the plan of care and implementation.
Women with Class 3 or 4 disease, surgery is recommended during pregnancy if symptoms cannot be controlled. Aortic stenosis is rarely seen as it normally develops after the childbearing years. However, if it occurs, treatment is similar to the treatment of mitral valve stenosis. There are other cardiac conditions that occur less frequently with specific management for each. These can be found in your book. The antepartum focus of care of the woman with a cardiac disorder is on minimizing the stress on the heart. Anything that significantly increases cardiac workload is avoided. Measures that can be taken to decrease workload include treatment of emotional stress, hypertension, anemia, hyperthyroidism, or obesity. Nutrition counseling may be used. Stool softeners and cardiac meds may also be administered. In the interpartum period, routine assessments are done with the addition of ABGs and possible hemodynamic monitoring. Again, nursing care is focused on promoting cardiac function. Maintain a calm atmosphere, elevate the patient's head and shoulders, and place in a sideline position. Vaginal birth is preferred. Episiotomy with vacuum or forceps-assisted birth may be done to decrease the time of the second stage of labor. Routine intrapartum antibiotics are given for prophylaxis. Oxytocin is given immediately after birth to prevent hemorrhage and changes in hemodynamic stability. In the postpartum period, monitoring is essential. The first 24 to 48 hours are critical as the maternal circulatory system returns to pre-pregnancy state. The woman may need as much assistance at this time to decrease stress on her system. Other medical disorders in pregnancy include anemia, pulmonary disorders, integumentary disorders, neurologic disorders, and immune disorders. You can learn more about these disorders in your textbook. The effects of alcohol and drugs on pregnancy are well known and include the continued use of substances despite related problems in physical, social, or other interpersonal areas. Substance abuse usually goes hand in hand with another psychiatric disorder. This is a dual diagnosis situation. As previously stated, the damaging effects of drugs and alcohol on the fetus are well known. Both can pass from the mother to the fetus. Smoking is considered a drug and can have serious effects such as bleeding complications, miscarriage, stillbirth, prematurity, low birth weight, and sudden unexplained infant death. Less than 10% of pregnant women who abuse substances receive treatment. Social stigma, labeling, and guilt have been shown to be barriers by Brady and Ashley. Losing custody of the baby is a big fear and a primary reason that many mothers might not report using. It is very important that a substance abuse screen be completed as a part of the initial assessment on the first prenatal visit.